Welcome, coding professionals. We're diving right into an advanced explainer on brain tumor pathology today. To code a complex neurosurgical chart with absolute confidence, you know you can't just memorize codes, right? You've got to truly understand the underlying clinical narrative. So today, we're bridging that exact gap between complex medical pathology and revenue-critical coding accuracy. Let's get to it. Here is what we're covering today. First, the roots of brain tumors. Then, tumor types and behaviors. Next, the brain's anatomical geography. After that, mastering ICD-10 diagnosis codes. And finally, variables for CPT procedural coding. Section 1, Roots of Brain Tumors, Cellular Disruption, and Risk. To code accurately, we've got to fluently speak the clinical language. That starts with understanding the core pathology. Basically, the fundamental mechanism of a brain tumor stems from a pretty devastating shift at the cellular level. In a healthy body, the normal cell cycle is an incredibly orderly, highly regulated progression of growth, division, and programmed cell death. But a brain tumor develops when this precise mechanism breaks down, leading to the uncontrolled abnormal division of cells. And what's wild is, because the brain itself actually lacks pain receptors, these masses often grow completely unnoticed. They just keep bypassing the body's natural stop signals until they start compressing or invading the incredibly delicate surrounding nervous tissue or meninges. So what actually drives this cellular disruption? Recognizing the primary risk factors in a patient's history is absolutely vital for us. Exposure to high-dose ionizing radiation, maybe from previous cancer radiotherapy to the head, is a major trigger. We also have to look really closely at inherited genetic syndromes. If you're reviewing a chart and spot conditions like neurofibromatosis type 1 and 2, tuberous sclerosis, Leaf-Romania syndrome, or von Hippel-Lindau disease, you should know the patient's risk profile just dramatically increased. We're also looking at weakened immune systems, like in patients managing HIV or AIDS, right alongside increasing age. Plus, occupational chemical exposures, specifically to harsh substances like vinyl chloride or formaldehyde, have been linked to slightly elevated risks. Grasping all these factors really helps you paint that complete clinical picture. Moving on to Section 2, Tumor Types and Behaviors, Classifying the Threat. Building on that, our next step is classifying these tumors by their origin and behavior because this heavily dictates your diagnostic coding. The crucial detail here is figuring out exactly where the tumor began. We categorize these into primary versus secondary or metastatic lesions. Primary brain tumors are native to the central nervous system. They originate directly within the brain or its immediate coverings. Common ones you'll see include gliomas developing in the brain parenchyma, meningiomas arising from the meninges, pituitary adenomas, and schwannomas. On the flip side, secondary tumors are metastatic invaders. They start from distant primary cancers, most commonly the lung, breast, kidney, or from a melanoma, and then travel through the bloodstream to dangerously seed within the brain. The coding pathways in your ICD-10 manual for primary versus secondary neoplasms are in entirely different categories, so making this distinction is paramount. We also absolutely have to classify the tumor's behavior. Differentiating benign from malignant growths is essential. Benign tumors are non-cancerous. They tend to be slow-growing and are often encapsulated, meaning they have clearly defined borders and don't typically invade surrounding brain tissue, though keep in mind they can still cause severe neurological deficits just from the pressure they create. A benign meningioma or a schwannoma are classic examples here. Malignant tumors, on the other hand, are cancerous, aggressive, and highly invasive. They lack those clear borders, sending roots deep into nearby healthy tissues, which makes complete surgical resection incredibly difficult for the surgeon. Glioblastoma multiforme is a prime example. It represents one of the most aggressive and truly devastating malignant brain tumors. Section 3. The brain's anatomical geography, establishing location. With the pathology and behavior locked down, we need to rigorously map out the anatomical geography of the brain. This is a massive variable in neurosurgical coding. To accurately code an operative report, you need to mentally map the brain structure. The foundational anatomical dividing line you need to know is the tentorium cerebelli. Just think of it as a tough structural tent or roof situated over the cerebellum. Structures located above this dividing line are classified as supratentorial. This includes the massive cerebral hemispheres. Structures located below this line are infratentorial, which encompasses the cerebellum and the brainstem. Knowing whether a surgeon is operating above or below this tentorial line is literally the very first fork in the road for your CPT code selection. Let's methodically attach some specific clinical structures to these two geographical zones. Starting with the supratentorial region, this contains the cerebrum, which is divided into the frontal, parietal, temporal, and occipital lobes, as well as the lateral ventricles, corpus callosum, and basal ganglia. Up here, we most frequently encounter gliomas, meningiomas, and metastatic lesions. Now, dropping down to the infratentorial region, this contains the cerebellum and the brainstem, which consist of the midbrain, pons, and medulla, along with the fourth ventricle. Tumors common to this tighter, far more critical space include medulloblastomas, brainstem gliomas, and ependymomas. And always keep the functional impact in mind as you're reading clinical notes. For instance, a lesion in the motor cortex might present as patient weakness, while involvement of the sensory cortex causes numbness, and a tumor impacting speech areas often results in aphasia.
Section 4. Mastering ICD-10 Diagnosis Codes, Clinical to Code.
Now we take all of this clinical and anatomical intuition we've just built and apply it directly to our ICD-10 diagnosis coding frameworks. Let's walk through some exact clinical scenarios, translating the specific site, behavior, and origin into definitive alphanumeric diagnostic codes. Say you have a diagnosis of a glioblastoma located in the frontal lobe. Well, we know a glioblastoma is an aggressive primary malignancy. In your ICD-10 CM manual, category C71 classifies malignant neoplasms of the brain. The specific fourth character, point 1, pinpoints the frontal lobe, giving us a precise code of C71.1. Now, consider a benign meningioma. We established earlier that this is non-cancerous and originates from the cranial meninges, so the appropriate code is D33.0, representing a benign neoplasm of the brain, supratentorial. Finally, imagine a patient with a brain metastasis originating from lung cancer. Because the brain tumor traveled from a distant primary site, it's a secondary malignancy. We capture this with C79.31, representing a secondary malignant neoplasm of the brain. See how that works? The logic flows perfectly from pathology to anatomy directly to the code.
Section 5. Variables for CPT Procedural Coding Surgical Translation.
Our final step in this explainer pipeline moves from the diagnosis to the surgical intervention itself, where specific operative details dictate your procedural coding. When you open an operative report for a brain tumor resection, you must methodically evaluate 5 crucial variables before you assign a primary CPT code. First, ask yourself about the location. Did the surgeon work in the supratentorial or infratentorial region? Next, look at the depth. Was the resection limited to superficial layers, or did it involve deep brain tissue? Then, consider the surgical approach. Did they perform an open craniotomy by removing a bone flap? Did they use a transsphenoidal approach through the nasal cavity, or maybe utilize a minimally invasive stereotactic method? Fourth, you must verify the lesion type. Was the target a primary tumor or a metastatic lesion? And finally, check for skull base involvement. Surgery near the complex floor of the skull requires massive multidisciplinary effort, highly specific approaches, and often reconstructive grafts. That pulls from an entirely different and highly complex set of CPT codes. Extracting these 5 variables is your literal key to unlocking the correct procedural code. So consider this. How does mastering this transition from complex clinical pathology to precise anatomical coding actually impact the entire healthcare pipeline? Think about it. The operative report tells you exactly what the surgeon did, but it's your clinical intuition that allows you to translate those complex surgical words into an airtight coded claim. Your precision ensures that patient records are clinically flawless, that epidemiological data tracking cancer rates is spot on, and crucially, that your facility maintains complete revenue integrity for these massive, life-saving neurosurgical interventions. But as surgical technologies like AI-guided stereotactic resections continue to evolve rapidly, will our current coding frameworks be able to keep up? That is a very real question for our next deep dive. Keep mastering these clinical frameworks, keep diving deep into the anatomy, and, as always, decode healthcare with Harshal.